$202.90 is being deducted from your Social Security check right now, every single month since January 1st, and most seniors receive no plain English explanation of what that increase is actually costing them this year. You were told your Social Security check was going up in 2026. What you were not told is that $17.90 of that increase was already spoken for before you saw it. And the institutions responsible for explaining that had no reason to make it clear. In the coming minutes, I am going to cover 4 specific changes that hit Medicare in 2026, all with exact figures, all already in effect. And before we are done, I'm going to share one specific action step for a group of seniors in 6 states facing something this year that almost no one has warned them about. It could affect a claim they have not even filed yet. Stay with me, because by the end of this, you will understand exactly what changed, what it is costing you right now, and what you can legally do about it. Before I go further, 2 things are probably running through your mind right now. The first is this: you already received your Medicare summary notice. You know what changed. You are up to date. Here is the problem with that. The summary notice you received, whether you are on Medicare Advantage or Original Medicare, was plan specific. It told you what changed inside your particular plan. What it did not show you was the combined annual cost of a premium increase, a deductible increase, and a new prior authorization requirement all landing at the same time, in the same year, on the same fixed budget. Those pieces were never added together for you. They arrived in separate documents, in separate months, in the language of policy, not the language of a household budget. The second thing running through your mind may be this: some of the 2026 changes are actually good news. Drug prices went down, and on that, you are right. That is not spin, and it is not something I am going to minimize. 10 high-cost medications now carry CMS-negotiated lower prices, effective January 1st, 2026. Nearly 9 million Medicare beneficiaries take at least one of those drugs, and for them, the savings are real. Out-of-pocket costs on those medications are expected to drop by more than 50% on average. That is a genuine win, and it deserves to be named as one. But here is what that win does not change. If you are not on one of those 10 specific drugs, and the majority of Medicare enrollees are not, the drug savings are zero for you personally. The premium increase is not offset. The deductible increase is not offset. The net effect on your monthly budget in 2026 depends entirely on which medications you take and which plan you are enrolled in. For many seniors, this year is a net loss, not a wash. A loss. So let me be precise about this because the details matter. There are 4 specific changes that hit in 2026, and every single one of them affects both Medicare Advantage enrollees and Original Medicare enrollees in ways that were never laid out together in plain language. That is exactly what the next several minutes are for. Now, why did none of this arrive with a clear explanation? It is not a difficult question, and the answer is not complicated. CMS announced the 2026 premium increases across multiple separate publications in actuarial language. No single document showed a senior the combined annual cost increase to their household. There was no regulatory requirement to produce one. Insurance companies offering Medicare Advantage plans had no contractual obligation to notify Original Medicare enrollees about the prior authorization change. Those enrollees are not their customers. The mainstream news covered the drug price negotiation in detail because it had a clear political narrative and a winner. The simultaneous premium and deductible increases arrived in the same policy package with no equivalent story to tell. Medicare plan brokers are paid on new enrollment, not on service to existing clients. A cost increase affecting a senior's current coverage generates no commission. There was no financial reason to call. The system that was supposed to explain these changes to you had no financial reason to be alarming about them. And that is not a conspiracy. It is simply how incentives work when your interests and their interests point in different directions. The 2026 changes to Medicare did not arrive quietly because they were small. They arrived quietly because the institutions responsible for explaining them had no financial reason to be alarming about it. You found out what you found out. The rest stayed in the fine print. Now here is the part that most seniors never see coming. The source of the analysis I'm about to give you, and why it matters that it comes from inside the system that built these rules. My name is Dr. Richard Voss. I hold a PhD in Health Policy and Economics from the University of Michigan. I am a certified Medicare Counselor. For 22 years, I worked as a senior policy consultant, advising federal health agencies and state insurance commissioners across 14 states. I walked away from that work in 2022 to publish what the industry does not want seniors to know. In 22 years of consulting, I watched the same thing happen every time costs increased. The announcement focused on one or two beneficiary-friendly changes: the drug savings, the new enrollment protections, while the premium increases, the deductible changes, and the structural shifts arrived in the same package with far less explanation. That pattern repeated itself in 2026 more clearly than I have seen it in years. That is the most expensive kind of policy update there is, because it arrives looking like good news. Here is the single idea that connects all four of the changes I am about to show you. None of them arrived with a plain English letter explaining the combined annual cost to your household. Each one was announced separately in the language of policy rather than the language of a monthly budget. And the gap between those two languages is exactly where the money disappears. That is the entire reason this video exists. Number 1. The Part B premium increase. The standard Medicare Part B premium increased to $202.90 per month in January 2026. That is the first number every senior enrolled in Medicare needs to understand, because it is the number being subtracted from their Social Security payment right now. In 2025, that premium was $185 per month. In 2026, it is $202.90. That is an increase of $17.90 per month. On its own, $17.90 sounds manageable, but annualized, that is $214.80 more per person per year. For a couple, both enrolled in Medicare, both having this deducted, that is $429.60 per year gone before a single prescription is filled or a single appointment is made. And this increase did not begin in February or in March after a notice arrived. It began January 1st. For seniors on Medicare Advantage, this Part B premium is paid in addition to whatever their plan charges separately. For seniors on Original Medicare, this is their primary monthly Medicare cost, and it sits $17.90 higher today than it did in December 2025. $202.90 has been leaving your Social Security check every single month since January. Not $185, $202.90. For a couple, that is $405.80 gone every month, before a single doctor visit, before a single lab result, before a single prescription is filled. That leads directly into the second change, because the premium increase did not arrive alone. It arrived alongside two deductible increases in the same year, and that combination is what most seniors have not been shown. Number 2, the deductible double hit. Both the Medicare Part B deductible and the Medicare Part D maximum deductible increased in 2026, simultaneously with the premium increase. 3 costs moved in the same direction at the same time. Most seniors track their monthly premium. Almost no one tracks the deductible until they actually need care. And that is exactly when the increase becomes impossible to ignore. Here is why that assumption is expensive. Deductibles are the money paid entirely out of pocket before Medicare coverage begins. When a deductible increases, the first dollars of every medical expense that year cost more. On a fixed income, those first dollars are not abstract. They come from the same monthly budget as groceries and utilities. The Part B deductible rose from $257 in 2025 to $283 in 2026, an increase of $26. The Part D maximum annual deductible rose to $615 in 2026. These are the amounts seniors pay entirely before their plan begins covering services and prescriptions. For seniors on a Medicare Advantage plan, plan-specific deductibles vary by carrier, but the Part B deductible applies any time original Medicare services are accessed, which many Advantage plans route certain claims through. For seniors on original Medicare, the full $283 Part B deductible applies before any outpatient coverage begins. Every time you see a specialist in 2026, every time you receive outpatient care, you are paying against a deductible that is $26 higher than it was last year. For anyone managing a chronic condition, multiple appointments, recurring prescriptions, routine monitoring, that $26 difference compounds across every single claim. Stay with me, because what comes next is the change receiving the least coverage of all, and it directly affects a group of original Medicare enrollees who chose that plan specifically to avoid it. Number 3. The prior authorization pilot. As of January 1, 2026, original Medicare now requires prior authorization for certain Part B services and supplies in 6 specific states. That sentence requires a moment to land, because for decades, freedom from prior authorization was one of the defining reasons seniors chose original Medicare over Medicare Advantage. You might think that because you chose original Medicare specifically to avoid prior authorization, you are fully protected from it. If you live in Arizona, New Jersey, Ohio, Oklahoma, Texas, or Washington, you are no longer fully protected for certain services. And I want to be honest with you before I continue. For decades, original Medicare's freedom from prior authorization was not marketing language. It was a real structural protection that distinguished it from every private plan on the market. What changed in January 2026 is specific and limited, but it is real and it deserves to be named clearly. A 6-year pilot program, running through December 31, 2031, now requires prior authorization for certain Part B services in those 6 states. The services include epidural steroid injections for pain management, cervical fusion, knee arthroscopy for osteoarthritis, skin substitutes for chronic wounds, and electrical nerve stimulator implants, among others. CMS uses artificial intelligence to review these requests, though the final coverage decision remains with a clinician. The program does not apply to Part D prescription coverage. For seniors on Medicare Advantage, this changes nothing. Prior authorization has always been part of how private plans operate. This pilot does not affect them. For original Medicare enrollees in those 6 states, this is a structural change to the plan feature they specifically selected to protect themselves. If you live in one of these 6 states and you are scheduled for a service that now requires prior authorization and no one told you, the claim can be denied after the fact. The care already happened, the bill has arrived, and Medicare said no. Which brings me to something almost nobody is talking about, and it may carry the highest financial exposure of anything I cover today, particularly for seniors who consider themselves comfortably middle income. Number 4, the IRMAA trap. More middle-income seniors are being hit with Medicare premium surcharges in 2026 than at any recent point, and the majority of them did not see it coming until the deduction was already appearing on their Social Security statement. Most seniors believe IRMAA only affects the wealthy. The income threshold for a single filer is $109,000. But that threshold is based on 2024 reported income, not 2026 income. Anyone who sold a home in 2024, took a large required minimum distribution, or completed a Roth conversion 2 years ago, may be paying a surcharge right now on income they no longer have. Now I want to be precise here, because the exact surcharge amounts depend on which income bracket you fall into, and what I can give you is the floor and the ceiling, and both matter. The IRMAA threshold for a single filer is $109,000 in 2024 modified adjusted gross income. For married couples filing jointly, it is $218,000. At the first surcharge tier, the total Part B premium rises from $202.90 to $284.10 per month. At the highest tier, it reaches $689.90 per month. Crossing the threshold by even $1 triggers the full surcharge for that bracket, $1. If you had a one-time income event in 2024, a home sale, a large RMD, a Roth conversion, and your income crossed $109,000 for that year only, you are paying that surcharge right now in 2026 on money you no longer have. IRMAA applies equally to original Medicare enrollees and Medicare Advantage enrollees. Plan type provides no protection. Both segments are equally exposed. And the appeal mechanism exists. It is called Form SSA 44, filed directly with the Social Security Administration. It allows seniors to appeal their IRMAA surcharge based on a qualifying life-changing event, including retirement, a significant income reduction, or the loss of income-producing property. Most seniors who qualify for this appeal have never heard of it. If you have not checked your current Part B premium statement against the standard rate of $202.90, there may be a surcharge being deducted from your Social Security check right now that you were never warned about in plain language. And this is exactly where it gets worse, because I promised you one specific action step for seniors in 6 states. What I'm about to tell you takes one phone call. It costs nothing, and it could prevent a claim denial you would never see coming. Now, before I get to that action step, I want to speak directly to 2 different groups of people watching this. If you do not live in Arizona, New Jersey, Ohio, Oklahoma, Texas, or Washington, the prior authorization pilot does not apply to your original Medicare coverage. You are not affected by that specific change. But everything else I covered today still does. The premium increase, the deductible increases, the IRMAA surcharge. You have more than enough to review, and the checklist I am going to give you before we are done will help you do exactly that. But if you do live in one of those 6 states and you are on original Medicare, there is one specific thing you need to do before you schedule any non-emergency procedure or request any durable medical equipment in 2026. Call your doctor's office directly before the appointment is booked. Ask specifically, does this service or this item now require prior authorization under the 2026 CMS pilot program? Not after the procedure, before it. Medicare will not call you to remind you this requirement exists. Your doctor's office may not volunteer the question. They are managing their own compliance, not yours. The responsibility for confirming prior authorization has been quietly shifted to the patient. And almost no one is telling original Medicare enrollees in those 6 states that this shift happened. That one phone call costs you nothing. A claim denial after the fact can cost you everything the procedure cost. And almost no one is telling original Medicare enrollees in those 6 states to make it. Here's what I want to leave you with before we finish. Seniors enrolled in Medicare Advantage assume that because their private plan sent them a summary notice, they understand everything that changed in 2026. Seniors on original Medicare assume that because they chose the simpler plan, the changes are simpler too. Both assumptions leave the same money on the table. Both leave the same claim vulnerabilities unaddressed. And they arrive at that identical exposed position from completely opposite starting points. The system did not need to hide these changes. It only needed to announce them in a language that most people would not translate into a monthly budget, and then wait. The 2026 Medicare changes were not buried. They were published in policy documents, actuarial tables, and regulatory notices. The gap between that language and a senior sitting at a kitchen table with a fixed monthly budget, that gap is not an accident. This channel exists to close that gap. And closing that gap starts with knowing exactly where you stand before the next enrollment window opens. So here is what I want you to do right now. Scroll down to the comments and tell me one thing. Which of these 4 changes hit you the hardest this year? The premium increase, the deductible, the prior authorization pilot, or the IRMAA surcharge? Write it below. Because the comments on this channel are where the real conversations happen, and your situation may help someone else who is reading right now and does not yet know what to do. If you are not subscribed, do that now. Every update I publish goes directly to your feed, and in 2026, being the last to know about a Medicare change is not a position you can afford to be in. Now, if someone came to mind while you were watching this, a spouse, a sibling, a neighbor, a friend from church, send them this video. It does not matter whether they are on Medicare Advantage or Original Medicare. Every single change I covered today affects both, and the odds are very good they have not been told about all of them. One share from you could be worth more to them than any gift you will ever give.